In the emergency department, different beasts, right? They're not gonna be able to do this. So what you do in the emergency department is you see if they can sit up on the edge of their bed and look at the clock, look at a big, much bigger target than your thumbnail. The clock, the exit sign, can you keep that exit sign stable in your vision? And most people are like, if I stare at it, yeah, I can get it to calm down. Because they're suppressing the nystagmus with their brain. They're already adapting. They're just staring and trying to focus and keep it steady. They're already making progress. So then you start to say, okay, so start turning your head a little bit, and they're not going to want to go to that left hypofunction side. They're going to go like this. You have to coach them to go over to that side. Ooh, I don't like this at all, Kristen. I don't like it at all. I'm like, I'm sorry, Esther, keep going. Okay, so you start in sitting, start at a target way bigger, way out, across the room, and they just try and keep it steady as best as they can. That's how you start. Now, I always say, like, then you progress to standing, and you progress to 3 feet back instead of all the way across the room. So the way, here, now I'm gonna just show you the slide here. And remember, this PowerPoint is in the share drive, so you're welcome to print it out, go back, look at it. Okay, so you do want them to walk the symptoms off afterwards. Even if they're acutely dizzy, you want to try to incorporate motion. And that helps the brain learn that motion is not offensive, motion is okay. And it helps them work through the dizziness faster. So you always tell them to walk it off. You always tell them they have to reduce their symptoms to baseline. Even if they're constantly dizzy. Let's say their intensity of dizziness right now is 6 out of 10 at rest. Okay, when you go home, it's okay to make it rise. And then as long as you walk it off and it comes back down to 6 out of 10, that's what we want. We don't want them to stay escalated for more than 20 to 30 minutes. Now, timing wise. So in the clinical practice guidelines for this, best evidence is 3 to 5 times a day, 12 minutes total. 12 minutes of this exercise total. So if you're doing this 3 times a day, that is 4 minutes of that exercise that you just did in a more kind of acute, subacute patient. Chronic patients, even more, 15 minutes a day. That's a lot. So that's expert opinion based on some evidence. But us in the clinical world, we're like, no, some patients are highly motivated and they will. And I say that to them, I'm like, really, the more you do this, the better, if you can tolerate it. But if you can't tolerate it, start with 10 seconds. But do it frequently throughout the day. Start with 15 seconds. Try to work your way up to 1 minute 3 times a day if you can. If you can't, it's okay. Somebody in outpatient will help guide you through the next steps. But this is what I want you doing for the next couple weeks at home.
How do you gauge the seconds? Just whatever they can tolerate without...
Whatever, yeah. If they are just they're out of control, they're about to vomit, their dizziness is too intense for them to tolerate, those are the 2 things that's a red light. And some of these patients have headaches too. So if their headaches start to escalate, you need to kind of dial it back. But you have to also keep in mind that it's okay to rev them up for a little bit. I mean, the slide says 20, 30 minutes. I usually say if it lasts more than 5 to 10 minutes and you're just miserable, you're probably doing a little too much. But these are some nice guidelines to go back to next time you see a patient in the emergency department. So you're educating a patient on frequent bouts of short distance walking. Work up to 30 minutes of walking if you can. Don't cocoon in bed. You're educating the patient. You're going to start this VOR exercise. And I give them the beat right when they leave. And I give them the printout, which is in the share drive. When you have it right there in your folder, it's also, like I said, it's in the share drive. So I get them going. I'm coaching them on VOR1 and walking. And then an important next part of the conversation is, okay, I'm going to go talk to your doctor now about what I found. So he may or may not give you some medication for this. They're definitely going to give you meclizine. And that's okay in the very acute stages, because a lot of times it helps people sleep better, it helps people function a little bit better, takes the edge off the severity. But as soon as you can get rid of the meclizine, get rid of it. So meclizine actually dampens the nervous system. It works against your ability to adapt to the problem. So it's counterproductive after the very hyperacute state. And make sure you're the one coaching the patient, because they will take it as directed on the bottle every time. And then it's working against you. So only as needed for meclizine. Zofran, you can take it all you want for the nausea.
The meclizine will help them not feel as dizzy, Zofran is just for nausea.
Correct.
Right?
But meclizine makes them super sleepy, which is a fall risk. And it's working against adaptation of the brain. So now you go talk to the doctor. And I highly recommend you take the laptop with you, and you say, look what I found. This is not BPPV, even though you told me to do the FLE. Look at, this is called nystagmus. It's always going to the right side. And based on my other exam too, the HINTS, I did the HINTS exam. This looks very much like a left vestibular hypofunction, a neuritis. So I know there's evidence out there that prednisone can help this. I don't know, it's up to you. If you want to give them prednisone taper, I know that's very helpful for short-term relief. Doesn't necessarily help long-term outcomes, but short-term relief, prednisone can be very helpful for these patients. So you present it like that to the doctor.
For neuritis mostly, because that's an inflammation caused by virus? Or-
Yes.
Yes, that's the only
vestibular
reason
nerve
why.
is inflamed.
Okay. But for the BPPV or anything else, it's not, right?
No.
Is that also like as needed?
No, it's a strict taper. It's taken as prescribed, the whole thing. Definitely had a couple patients come back and be like, wasn't doing anything, so I stopped taking it. It's not Advil.
Right, I only take it when I need it. Like,
Right, take the taper.
oh.
And that's another really important, oh, nobody told me that this wasn't up.
It went off when we were doing that.
Oh,
Yeah.
okay. Sorry. So, the medication piece of education is important too. And then the way you phrase it to the doctor, like I said, I always try to prove it to them. I show them the laptop and they're like, wow, that's cool technology. And now there's this connection and they understand what we can do better. There's buy-in from them. And they're like, oh, okay, I guess that's not BPPV. Okay, and they believe you more when they see it. So try to do that. Then, after you recommend, hey, if you want, give them some prednisone. You give me the medical record number if you're here in Vallejo. And I follow up with them, I track their chart, I see how they're doing. I call them within a week, maybe 2 weeks, depending on what's going on in the clinic. And I get them in with either myself or another vestibular PT. Ideally, what we would do is if you're the emergency room physician who caught this, I would bring you in for mentorship. I'd block your schedule and say, I'm gonna see Esther on the 11th, you're gonna come in with me and you're gonna see what she's like 2 weeks down the road. I've been able to pull that off a few times. I can't do it every time, but I try as best as I can to get you involved so that you can see the vestibular rehab a little bit down the road. So you forward me the medical record number, whether it's Teams, Chart Chat, just within Health Connect, you can forward me the chart, whatever is easiest for you. But I need the medical record number and a little bit of a synopsis about what happened. Would be nice. And it's a pretty nice, streamlined care for these patients. You know, we really get them going and make sure, because really early rehab and consistent vestibular rehab is in the clinical practice guidelines. It's excellent evidence over vestibular rehab for these patients.
How many patients a week do you see vestibular-wise about?
I usually have 3 or 4 evals a week. Caleb has, I think, 2 on his schedule. Cadigan has probably 4. She gets a lot of 40-minute evals too. She has 60-minute blocks, but she's got a lot of 40-minute musculoskeletal that they'll put 40 minutes in there, and she's always like, ah, I know. There's a lot of vestibular patients. Now that they know how good we are, you ask, you shall receive. That's why we need more people to be able to see everybody. Okay, now just to stay on VOR a little bit more, the VOR times 2 is they'll be holding the target and they'll be going left to right, opposite like this. So I don't find much value in VOR two. I don't think of it as a progression. They can anticipate where the target is. It's not like it's random and spontaneous, and a lot of people get shoulder pain with it. So what I've kind of shifted towards more in my career, if I'm gonna progress the VOR exercise, can I have you guys stand up again and we'll try a couple things. So line up again and find your fastest speed while keeping the target steady. Just kind of get back into that rhythm that you already found. Good. Now what I'd like you to do is march in place while you keep your head moving. So that's a little bit of a progression, making it a little bit more dynamic, a little bit more difficult. Good. Keep your head moving. Now stop. Keep your head moving, but stop your feet. Keep your head moving. Okay. Now Oscar and Stephen, be careful here, but another one would be take 3 steps forward and 3 steps back. Okay, so you're walking during the VOR. It's harder, right?
So me, I need it because I get pretty dizzy.
A little bit of dizziness is okay. So let's have you line up again. Now try vertical VOR, up and down, like you're shaking your head. Yes, about 30 degrees up, 30 degrees down.
What if it doesn't?
Hmm?
What if it doesn't?
The vertical is a little more challenging. It's harder to coordinate, and for people who don't have any issues, I do think it's hard to make the target move because the neck doesn't move as easily, as quickly into vertical. We don't like to say yes as much as we do like to say no. But this is also part of your vestibular rehab if needed. So a lot of times I start with horizontal. Okay, you can pause there and we can chat for a minute. A lot of times I start with horizontal because it's the most functional, and I want to see how the patient's doing with just that one exercise, and I want to overload them too much. But they come back and they're like, I'm still having oscillopsia. Have you guys heard oscillopsia? It's the bouncing of the vision. You take a step and your vision is not matching your footsteps, so there's this waviness, bouncing of the vision. So a lot of times the vertical VOR can help the oscillopsia that people complain of. Or people who are, they're working and they're moving their head a lot between computer and their notebook or whatever, they're looking down and up and they get a lot of dizziness. I'll implement the vertical VOR to help stabilize in that plane of motion. So I'm making it kind of more specific for people with vertical motion complaints. So I always check both, but I don't always give vertical as an exercise. Horizontal is much more functional. And then you can, later down the road, you can adapt the VOR exercise to a lot of different things. So a lot of people have an issue in the car with driving, and they'll hit a bump and they'll have oscillopsia, or they're trying to check their blind spots. So sometimes I have people sit on a physio ball, and I just have them go physio ball, they're just bouncing, kind of simulating a little bit of the rocking of a car, and then doing the VOR on a physio ball. So that's another classic one. So if you learn how to teach the VOR times one with marching in place is the next nice step. VOR with 3 steps forward, 3 steps back. And the patients can adapt to those, usually those 3 exercises, and they nail it. A lot of times they're recovered by then. But then you get into, again, maybe you have to do vertical work also. And then maybe you have to do a little bit more specific training. So I had one electrician, for example, he was working up on like high rises and on cranes, and he'd be looking at an iPad and then looking down at the job, and every time he would be moving his head, he'd get dizzy. So I had him do the VOR in head flexion to match exactly what he needed. So you could do it different planes of motion, and if you take a good subjective history and see exactly what activities are making them dizzy, you base the VOR around that. Kind of simple rules. And it's the same thing. It's like, okay, 60 seconds, 3 times a day. The more you do it, the research shows it's actually a little bit better if you can tolerate it with your neck.
Does that have anything to do with depth perception? Like
For that guy?
for that guy or for the oscillopsia? Like, does that?
Yeah, I mean, it depends. For him, he was done with all of his dizziness except that one at the crane height. And I wasn't sure if it was depth perception or not, but I was like, let's try the VOR and see if that's helpful. And it was, so I didn't need to think any further about it. But depth perception usually improves also as their VOR stabilizes. Kind of
Okay.
usually married together. Okay. So then there's also 2 target VOR. So VOR times 1 with the B that we just did. VOR times 2 equal and opposite, which I don't find much value in, but you're welcome to try it with your patients if you feel like it might be helpful. 2 target VOR. This is another category of VOR. So this, to me, this is, if we need to take a step back, they're actually too symptomatic. They can't tolerate VOR1. And a lot of people who can't tolerate VOR1 are a lot of neck pain, a lot of anxiety, a lot of nausea. Those are like the top few reasons why they can't do it. So we'll kind of scale it back and I'll do 2 Bs. Same exact target, a little bit away. And it looks like this. You move, eyes jump to 1B, then the head. Eyes, head, eyes, head, eyes, head. So they have to stabilize first, move their head after. This is a little easier than the VOR1, and sometimes I have to just start here to then progress to VOR1. So 2 target VOR. It's a step back from VOR1. I also find this very helpful. I'll let you guys finish writing that, and then I'll say what I was going to say. I find this helpful for a major functional complaint, which is checking blind spots with driving. So I'll say, look behind you, like really visualize where your blind spot is. Literally hold your hands up like you're in your car, steering wheel. Stabilize, and I'll be like, is the V good here? Should I put it here? And like move it a little bit to the left. In my car, it's a little bit over there. So okay, look over there, stabilize it. Now come back to the center. Now we put a B over there, stabilize it. Okay, I got it. Now come back to the center, and they look at another target in the center, and they do that repeatedly. And in the beginning, when they go to the hypofunction side, they're like, oh, okay. Takes them a little while to stabilize, and then they do it repeatedly, and they can usually learn to stabilize with those 2 targets. And that might not just be the blind spots. That could be whatever functional tasks they have to do in their lives.
What's the exercise called again?
VOR,
2
target VOR. A couple other quick things about the VOR exercise. There's a lot of popularity in going to more complex backgrounds. So you'll do the B on, you guys all have nice plain backgrounds. And then, especially at my old job, we used to use checkerboards and tell people to put it on complex wallpaper at home. Like the curtains in our booth, you can like maybe safety pin it on there, or any sort of target with a complex background. So that's another thing that you could progress to, is a complex background. Some more recent studies show it's not as valuable as like duration and treatments, function specific VOR exercises, so I've kind of fallen away from changing the complex background, but it is an option if you want to put that in your practice. So the VOR printout that you guys have here. So I did this to every patient with a copy of the B. I've actually made some laminated Bs that are business card size, so they can keep them in their pocket or wallet, and it's a neater way to do it. But anyway, so I explain this to them, and I say, I read it to them, like this exercise, like we talked about, it's going to cause dizziness when you do it. That's actually kind of the point, is to make you dizzy. Rev up the symptoms, walk it off after, so that you get back to your baseline. And it's okay, don't be scared of it. You have to push through the dizziness a little bit for your brain to adapt. The point is to work through it. And then walk the symptoms after until they resolve. You want to do this at least 3 times a day and spread it out. Don't just be like, I want to get this done before work. Bam, 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 and you're done for the day. You actually should do it breakfast, lunch, dinner, maybe once in between if you can. And then I explain, these instructions are pretty clear, but the other thing I want to make sure that I say to you guys with this, you want to really make sure that they're understanding that the exercise can make them feel better. So after you do the exercise, you're feeling miserable, you walk it off. Most people will feel more grounded after. It's like, feel like I can move my head better in the world after I do this annoying exercise. And I say annoying, it's a really annoying exercise. You guys probably all felt it. It's hard on the necks, it's boring, but people actually like doing it once you get buy-in. And I say bring it to work or school, put it on the back of the bathroom door, close the door, nobody has to know what you're doing, and you could get it in throughout the day. And a lot of times it grounds people, it makes them feel better so they can get through the next chunk of their day. So they use it like medication once they realize that it feels actually pretty good to do it. Okay. All right, any questions about the VOR? So let's go on to VSR, the second category of your vestibular rehabilitation. So the vestibular spinal reflex sends signals to your postural muscles, especially your extensors, so that you stay upright. If you're going out of your base of support, your VSR kind of corrects your balance and is our third system of balance. So you got your vision, you got your somatosensory system, number 2, as a backup. Joint receptors, your skin, under your feet. And then number 3 is your vestibular system, specifically VSR helps with balance. So VOR is visual stability, VSR is actually your balance system. 2 separate, distinct jobs in the same system. Right, so down here, the sac, the otolithic membrane, that's where all those calcium crystals are. Those crystals sit on a bowl of jelly. As you move your head, they send signals to your postural muscles. The canals are filled with fluid. They have the hair cells right at the base and the ampulla, and as you move your head, the fluid moves, bending hair signals, excitation, inhibition, and that's what creates eye movement. Okay, so when we talk about the VSR, we're talking about the otolithic membrane, okay? So we have 2 separate categories to treat for when we're rehabilitating the vestibular spinal reflex. And the first is static balance. So let's have some fun and go ahead and stand up. So some patients with VSR complaints will say, you know, I'll just be talking to people and I'll be moving my head and I'll lose my balance, or just even standing still, I can't quite find center. I feel like my body is off kilter, my gyroscope is off a little bit. So this is people who have had a neuritis or any sort of vestibular problem. If their VSR is bothering them, it's not functioning properly, those are kind of the complaints that you'll hear. And you'll see this teasing out in your exam. One of the best things to do is the Romberg exam. So put your feet directly together so your heels and toes are touching, and not everybody can do this with valgus knees or body girth, but you get the feet as close together as possible. Hands across your chest so you're not cheating, and out like this on a tightrope. All right, this is too easy. You want it to be all in here. So now if you go ahead and close your eyes, you're taking the vision away, which is your primary source of balance. So everybody sways a little bit, right? You probably can feel yourself swaying a little bit, and patients get mad at themselves if they sway at all. Like, well, it's normal. I just took away more than 1/3 of your balance system. All right, so this is the standard Romberg position. I usually see if people can stay here or if they're falling over for about 20 to 30 seconds. Now, if they're falling over right here, I'll usually cue them to use their somatosensory system conscientiously. So think about where your feet are in space. Is your body weight over your feet? And then go up to your knees. Tighten your quad muscles a little bit. I usually say squeeze your knees a little bit, and that usually stabilizes the knees. Now go up to your butt, go up to your glutes, squeeze your glutes a little bit together, kind of tuck your tailbone under you, and that stabilizes the pelvis a little more. And go up to the belly button and engage your belly button, suck your belly just a little bit. And now bring your shoulder blades back a little bit, make sure your chin is on steady. And then check all over again. Go to your feet, go to your knees, go to your glutes, go to your belly, go to your shoulders, go to your chin. So I do this check all the way up and down the chain, so they're thinking about their somatosensory system with vision blocked. So now they're using, you can go ahead and open your eyes. So now they're using somatosensory consciously and some vestibular. Right? You can't just isolate one system ever, but you're biasing those 2 systems. And when I have them do this exercise at home, I have them doing those checks also, and then they're conscientiously doing it every time they do the exercise. Now, the printout that I gave you guys for static balance, we call it the Romberg progression. If they can't do that with their feet apart, with their feet together, I have them put their feet apart. And I have them get kind of as close as they can to where they can tolerate they can do the exercise for 1 minute, and they're not falling over, but it's not too easy. So for you guys, you all nailed the Romberg, right? I would make it harder. But if somebody's falling over every 2 seconds with the Romberg, then I'd have them say, put your feet a couple inches apart. If that's still too hard, put them more apart, until they can do it. I don't care how wide, you gotta start somewhere to be able to really cue in the somatosensory and vestibular system. Okay, now for you guys, let's go to the quarter Romberg position. So you're gonna put your big toe, slide one big toe back to the bunion area. Just a quarter way up the other foot. Same thing, hands across your chest. And then get ready and go ahead and close your eyes. This is probably pretty easy for you guys. Switch feet, put the other foot 1/4 of the way up the other. The foot that slides behind is the foot that tends to do more work. So people feel a lot more confident if their dominant foot is behind. So if you're gonna kick a soccer ball, if you kick a soccer ball with your right foot and your right foot is the one slid back, you're probably gonna be more successful. Now, good, let's do the half Romberg. One foot goes halfway up the other. Tiny bit harder, really not much for you guys at all. Now try 3/4.
These progressions have actually felt easier than
They
the
have.
Romberg.
You're very special.
Short but special.
Now try 7/8. So the heel is right next to the big toe. Now try heel directly in front of toe, so tandem stance. Squeeze your glutes, squeeze your quads, tight belly, shoulders back. Now compare that to the other foot being back and switch your foot position.
Oh, yeah, that's better.
Okay, now keep in this position, open your eyes. Now turn your head right to left. Spot 2 targets on the opposite side, as far as your head can go. The quicker you turn your head, the harder it is. You can do head tilts. This stimulates the otoliths a little bit more. Now, try this with eyes closed. So there's a series of progression of difficulty. You can also go to single leg stance. Okay, that would be, especially for older people, it's much harder. So that's the series of progression, and you want to tell people, you want to find in the office what the hardest, what the one is that they can do for 1 minute, but it's hard. If it's too easy, it's not working. If it's too hard, it's not working. So I'll circle it. I'm like, okay, quarter Romberg was a pretty good challenge for you, but you were able to do it. And then I'll draw arrows that hop to the next progression. Now, try it the next week. If you feel like you've mastered this position, go to the next one, then go to the next one until maybe you get to this tandem stance. I don't care if you do or not. You probably couldn't have done that before this big vestibular insult, but we want it to be challenging every day. So I usually coach this as, let's say it's the half Romberg position that we land on that they're gonna do at home. Do it right foot in front for 1 minute and then left foot in front for 1 minute. The next day, try it on carpet, barefoot. The next day, try it in your sneakers, because people wear, 3 or 4 types of shoes usually, right? So try it in each one of your pairs of shoes. Try it barefoot, try it on carpet, try it on hardwood, try it on a trampoline. So you can make it fun every day, make it a little bit challenging, so it's not quite as tedious and boring. The other big piece of information about a home exercise program for the VSR is doing it in the corner. For safety. You guys don't need to do that. Most patients need, and they need to know that they're safe. And a lot of times I'll have patients put a chair in front of them or their walker and supervision if needed. But this is, usually patients feel pretty safe in a corner and not too close to it so that they're leaning on it, but not too far away that they're gonna have one leg rip their skin open because you wham. So just careful, keep them kind of tight in there, but not too tight. So that's a really nice way to work the static VSR, and it's, I usually say twice a day for 1 minute. Very easy to embed that into people's days. Okay, now, the second type of vestibular spinal reflex exercise is adding ambulation, so more dynamic. So let's go to the hallway.